Next, I would like to involve Dr. Swati Kalki ma'am. She is a brilliant surgeon, and she is going to talk about something that is not in the theme that we are working right now, because we always think innovation is just about getting idea and making products, but it is not. You innovate in your surgeries also, and that surgical step can be your signature art. So over to Swati ma'am.
Thank you, Nilesh. Good morning, everyone. First of all, thank you for including me in this instruction course. I think we don't have too much time, is it? 8:55, I think. Okay.
We can have two
I'll
quick
try to do
presentations.
it
Yeah.
in 5 minutes and let Ashish take. Okay. So today I'll be talking about the small modification that we did for the treatment of ocular surface squamous neoplasia. I do not have any financial disclosures to make, and appropriate consent has been taken for the use of photographs that I will be using in my presentation. So often we come across cases of ocular surface squamous neoplasia where they're not responding to medical treatment. And when they're not responding to medical treatment, the obvious treatment becomes surgery. And when we do surgery, obviously, it may not end the way that we want them to. Like in these cases where the patients develop limbal stem cell deficiency, the first case being a total, and the second being the partial limbal stem cell deficiency. So the next obvious step when they develop LSED is to go ahead and do SLET procedure, which has been, I think, being used for the past decade. And that's what we did in these cases. And after the SLET was done, as you can see, it's gone back to what it started with. That is, there was recurrence of the limbal stem cell deficiency. So, which clearly means that when we do SLET as a secondary procedure, it's clearly not working in these cases. Now, if we look back at the background as to why this has occurred, it's mainly because these cases with OSSN already have loss of limbal stem cells. So there is limbal stem cell deficiency that is existing, and the surgery kind of adds to it, and that causes surgery induced limbal stem cell loss as well. Now, if we look at the solution, as I think we have heard in the previous talks as well, how we have to try to solve the problem. So the main problem is that there is loss of limbal stem cells, and that's what we have to replace. Now, when we have to replace, we have already tried the secondary SLET, which clearly didn't work. So we wanted to see if primary SLET actually works in these cases. The traditional way of treating an ocular surface squamous neoplasia is like we remove the tumor along with 4 millimeters margin, and in the process obviously we will be losing the limbal stem cells at least 2 clock hours more than the size of the tumor. And on the corneal side we remove about 2 millimeters of the corneal epithelium. This is a standard procedure, and we do double freeze thaw cryotherapy to the margins. Now, when the loss of the conjunctiva tenens and the corneal epithelium, we are obviously replacing with an amniotic membrane graft. But traditionally, what we have not been doing is not accounting for the loss of the limbal stem cells, and that's what we aim to do. That why don't we combine the SLET as a primary procedure when we do OSSN surgery? That was a small tweak that we did in the surgery. But for this, we needed to understand whether this modification is required in every case of OSSN that undergoes surgery. So for this, as you can see, this panel, it shows like various sizes of the tumor that it presents with and various locations. So we needed to understand whether we should do SLET in every case. So for this, we did a retrospective analysis to understand which are the cases which are at risk of developing this LSCD. So we did a retrospective analysis of the cases who had undergone excision biopsy without SLET. And what we saw was that when the tumors were small, less than 6 clock hours, they did not develop limbal stem cell deficiency, as you can see in the pictures on to the right, or rather to your left there. um, the cases which actually develop limbal stem cell deficiency are those where there was loss of more than 6 clock hours of limbal stem cells. So as the table shows there, when there is loss of less than or equal to 4 clock hours, the limbal stem cell deficiency chances, I mean, they do not develop. 5 to 6 clock hours, about 50% of the cases can still develop, but more than 6 clock hours, almost every case develops LSED. So we went ahead and started doing the SLET procedure in these cases where there was more loss of more than 6 clock hours of limbal stem cells. So this is the procedure. I hope it plays. Yeah. So this is the traditional way. So we will excise the tumor, do the double freeze thaw, place an AMG, harvest the limbal stem cells, sometimes from the opposite eye if there is loss of the significant limbal stem cell clock hours in the affected eye. Then we do the standard process of how we do a SLET, where the small limbal stem cell explants are placed, glued, so that they remain in place, and the BCL is placed. Now this is what it looks like. This is I think about 1 week post-op, where we can see an amniotic membrane graft and the SLET particles. And this is the OCT of a standard SLET procedure. When we do that, we see that day 1 the transplants are seen. Day 5 we already see that the epithelium is slowly growing. By day 8, almost there is a bridge between the two SLET particles. Epithelium is grown, and by 3 months these SLET particles completely disappear and the cornea is nicely epithelialized. Now, these are the examples where we did the SLET as a primary procedure, where you can see that these are large OSSNs, where there definitely will be loss of more than 6 clock hours of limbal stem cells. We did primary SLET in these procedures, and you can see this is post-operative, where none of these patients developed limbal stem cell deficiency, because we did this as a primary procedure rather than waiting for the complication to develop and then taking care of the complication. And this was the pilot study that we published, and now we continue to do the SLET procedure as a primary procedure when we know that the loss of limbal stem cells will be more than 6 clock hours. So, in conclusion, primary SLET after excision of OSSN involving more than 6 clock hours of limbus, it prevents or at least minimizes the signs of LSCD, because in the pilot study where we studied 7 cases, none of the cases developed LSCD. But now that we have more than 25 cases where we have done this procedure, still less than 5% of them can develop some signs of limbal stem cell deficiency, but nothing visually significant. So, with this, I conclude my talk. Thank you.
Thank